Good evening, everyone. Welcome to my IVF Answers. I'm glad that you are all here. Thank you already for joining, and I'm really excited to listen to what has Dr. Elena Santiago. As you can see her right here, she has prepared a presentation for us tonight, and I'm really looking forward to it. So, Dr. Elena, thank you so much for joining. How are you feeling tonight?
Hi, good night. Thank you so much for having me again here at my IVF Answers with the webinars. I'm very happy to be with you again. So I hope that today's topic is very interesting for everyone and that we learn something new today.
I am sure we will. So thank you so much for joining. It's been a while. You have done some webinars in the past with us, but it definitely has been a while. So thank you so much for coming back. And let me just mention that, as always, we will start with Dr. Santiago's presentation, but afterwards there will be time for your questions. All you need to do is just type those in the chat section. And of course, we will, Dr. Santiago will try to help you out with those. And remember, it's being recorded. I'm your host, Caroline, and I just want to say that if you haven't been on our webinars before, we are simply here to educate you, to provide you with some answers, but also to help you out with anything that you might need. Those webinars are definitely dedicated to all the patients. As you know, there are plenty of topics we've done, and there are so many topics that we are still planning. And of course, I hope that those are useful for you. And I also would like to add that nowadays we also have webinars in Spanish, Italian, also French. So if this is something that you would be interested in, I can only advise to go to our website, myivfanswers.com, and there will be an option to find other webinars as well. And plus, one more last thing before we start. If you wish to volunteer for European Fertility Society and my IVF Answers, there are some ways to do so. I have put a link in our chat. So if you would like to get some more details, please check this website, and we'll be happy to help you and also answer any of those questions that you might have. And yes, now I think it is time to start our webinar. Let me just add that Dr. Santiago is the fertility specialist and gynecologist at Tambre, Clinica Tambre, which is located in Madrid. So I'm very happy that you are back, Dr. Santiago. And let's go ahead with our topic tonight. It's definitely an interesting one. So are you ready?
Yes, thank you so much.
Thank you so much indeed. And let's go ahead.
Okay, so welcome to everyone. As Caroline said, I'm Dr. Elena Santiago. I'm a fertility specialist in Clinica Tambre. And today's topic, we're going to talk about the endometrium, basically. But we're going to see how we do normally at the consultation or during any of the procedures to have a well-prepared endometrium for an embryo transfer. So first of all, what are the topics, all the things that we're going to cover today? We're going to see a definition for endometrium. We are then going to see different types of preparation regarding, for example, fresh embryo transfer, frozen embryo transfer. Also, we're going to see different options for endometrial tests that we can do, see when maybe it's indicated or not. And to end, we're going to see all the conclusions. So, what's the endometrium? The proper definition is that tissue that we have inside the uterus, okay? This is the innermost layer, and where the implantation of the embryo is going to take place for afterwards the fetus development. This tissue is special in women's organism because it changes depending on the timing of the, let's say, of the cycle, of the ovarian cycle. So there are different moments where we get different types of endometrium, but everything is thought so that we can get that pregnancy correctly. All right. So due to the ovarian hormones that we produce during a natural cycle, the endometrium is going to change. And first of all, the estrogens are the, let's say, highest levels of hormones. The estrogen help to produce this lining to thicken for a potential pregnancy, but afterwards we also will need progesterone. The progesterone is produced after the ovulation, and this hormone helps supplying the lining and stimulating the glands to grow and nourish the early embryo. So logically, this is a very important part of our organism during a fertility treatment too. And there are different ways in which we can prepare the endometrium for an embryo transfer. As I said, we're going to look at when we can do and when it's well prepared an endometrium for a fresh embryo transfer during an IVF, and how we're going to do an endometrial preparation for a frozen embryo transfer. Here we are going to talk about the two basic options of endometrial preparation. It can be during a substituted cycle with a hormonal treatment, or sometimes also we can do a natural modified cycle that I will explain you later. So, what are the requirements for a fresh embryo transfer to take place? This is when we're doing an IVF cycle after having done the ovarian stimulation and the egg retrieval. We are going to see if the woman is prepared to do that fresh embryo transfer several days after the egg retrieval. This can be 2 days after, 3 days after, 5 days after, depending on what stage of the embryo we want to do the transfer. No, just mention that normally, for example, in our case, we do the embryo transfer in the 5th day of embryo development. This is the blastocyst stage, and maximum it will be in a 6th day of embryo development, when maybe the embryo goes a little bit slower, but still has a good quality for an embryo transfer at that point. The requirements are very important too. It doesn't mean that, okay, if we do an ovarian stimulation, then we're ready for sure to do this fresh embryo transfer. We do need some concrete, let's say, we need some things going on. Not only a good endometrial lining, which should be a 3-layer endometrium of about or more than 7 millimeters of thickness. That's the best option. But also we need to check, for example, the hormonal levels of progesterone the day of the trigger before we do that egg collection. So these progesterone levels should be less than 1 nanogram per milliliter, because if they are higher, it means that maybe the window of implantation could be affected, and therefore it's not good to go ahead with that fresh embryo transfer. Also, very, very, very important, when doing a fresh embryo transfer during an IVF, we have to take into account that there could be a risk of having a hyperstimulation syndrome, or what we call OHSS, right? So here, if, for example, we've been having loads of follicles growing during the stimulation, such as we have more than 15 follicles, more than 16 millimeters the day of the trigger, is better to let's freeze the embryo and do a transfer later on, so that we don't get that risk of hyperstimulation syndrome. Also, hormones here are going to help us to know if there is an added risk. So not only we are going to see the progesterone levels, but also the estrogen levels. If they are higher than 2,500 or 3,000 picograms per milliliter, it means that probably that woman has quite a risk of developing an OHSS afterwards when she gets pregnant if the embryo implantates. And last of all, also we have to check the number of eggs that we did retrieved, because if we have more than 15, the same is better if we freeze the embryo and go ahead with an embryo transfer at another cycle, so that we absolutely get rid of the risk of an OHSS. Second of all, we're going to talk about the frozen embryo transfer, which nowadays is, let's say, much more common than a fresh embryo transfer, because all the reasons that I've spoken before, there are quite a little number of fresh embryo transfers. Also, as we are using a lot nowadays, the PGS testing of the embryos, then at this point we also need to freeze the embryo normally after the biopsy, so that we can wait for the genetical results to come back. So therefore, at least at our clinic, we do loads and loads, each time more, frozen embryo transfer. So we have different ways of preparing the endometrium, as I said. The first option will be with a substituted cycle. It's the most common preparation that we use nowadays, because it's easier to plan and we need less ultrasounds to be done during the preparation. Here, we're going to give estrogens exogenously, so it means that we're going to give a treatment with the hormone estrogen from the start of the cycle, and this medication can be taken orally, transdermic with patches or creams, or even vaginally. So how does this, let's say, protocol work? What are the steps that we need to follow? So normally we will need a first ultrasound at the start of the cycle, meaning normally when we get our period at the second or third day of that period, to check that the ovaries are resting and that the endometrium is quite thin or a little line. Obviously, you will think about also women that maybe don't have cycles because they are already in a menopause or have irregular cycles. With that women as well, we can absolutely do this type of endometrial preparation. There's no problem. And to see we can get started, also we will need an ultrasound, see what's the situation. Obviously, if we have also ovaries resting and a thin endometrium layer, then we can go ahead directly. Other times, if maybe the endometrium is not so thin or the ovaries are working, even if we don't have periods, we will maybe need to provoke a period before getting started with the estrogens. But for sure, we can use it in either way. So when we confirm that everything is good at that first ultrasound, we will start the estrogens. And normally around 10 to 12 days after taking them, we will check with the second ultrasound that the endometrial lining looks correct. This means, again, a 3-layer endometrium with more than 7 millimeters of thickness. Sorry, because I see now that we've put 3 millimeters. It's not, that's not correct. It's more than 7 millimeters, the same as we were talking with a fresh embryo transfer. And also here, the same, we're going to check at this point that the progesterone blood levels are lower than 1 nanogram per milliliter. So it's absolutely the same as with a fresh embryo transfer. If things are fine, then we would add progesterone 5 days before we're going to do the transfer. This normally we add it vaginally with a protocol of 400 milligrams per, each 12 hours. Or also we can use directly subcutaneous progesterone. Normally it's 25 milligrams each 12 hours too. If we are using the vaginal progesterone, it's important that 1 or 2 days before doing the transfer, we check again our progesterone blood levels to see that they are correct, meaning that we are absorbing properly the medication. Loads of patients maybe can get levels of progesterone under 10 nanograms per milliliter, and this is considered that it's not enough for a proper embryo implantation or a developing pregnancy, okay? So it's very important that if we don't have at least 10 nanograms of progesterone in our blood, we do need to add subcutaneous progesterone to the vaginal one so that we make sure that our levels are going to be correct. In a natural modified cycle, the steps will be, here we're going to do ultrasounds, normally not from the start of the cycle, but from like 1 week after we got our period. It's true that we need more ultrasounds to check the natural cycle, how it goes on. Normally we will see patients each 2 to 3 days. Here as well, we look at having a 3-layer endometrium more than 7 millimeters again, but also we're going to check that in our ovaries, the dominant follicle that is growing naturally has at least 16 millimeters, so that we can schedule the transfer. How do we do that? That's why we call it natural modified cycle, because what we're going to do is provoke the ovulation before it occurs spontaneously, so that we can completely know exactly when the window of implantation is going to take place. So what we do is put a trigger with HCG, such as when we do an IVF, to produce the ovulation, and exactly 7 days after, we're going to schedule that embryo transfer. We are going again to add progesterone 5 days before the transfer, exactly the same. If it's vaginally, we will put the same protocol, 400 milligrams each 12 hours, or we can do it with subcutaneous progesterone, but this time we will only need 1 injection each day, because our ovary is also producing progesterone by itself. So that's the reason why as well there's no blood test for progesterone levels needed with this type of protocol, as our ovary is producing endogenously the progesterone as well as the one that we are giving extra. There's no need to check the levels at this point. So let's see a little bit about the pros and cons, of using the natural modified cycle. It has its pros, obviously. We're going to use less medication, so estrogens are not needed at this point, and therefore without the estrogens, maybe we can have less side effects for many patients. But obviously also it has its cons, meaning that only we can use it in women with regular cycles. We're going to have less planification, meaning that the transfer will need to be scheduled when the natural cycle more or less is telling us or how it goes. We can't handle it as a substituted cycle, maybe with more options of scheduling the transfer at another point. Here also we need normally to do more ultrasounds to follow up the natural cycle, and there is more probability of cancellation due to spontaneous ovulation. This can occur in the 2 types of preparation, but it occurs more probably at this point with a natural cycle. And then now I want to just speak a little bit more about endometrial tests. This is something that we don't need to get done with every patient. It depends on the case, but I want you to understand that we have other options, maybe to look at a little bit more the endometrium and have more information. One of the tests is for the endometrial receptivity. We were talking about the window of implantation. This is known to be a period of time when the endometrium is really with best conditions for an embryo implantation to occur. We say that the endometrium is receptive at that point, and normally it lasts around 3 days only. It should be more or less in every woman the same window of implantation. But we've seen, after lots of research and lots of testings, DNA testings of the endometrium, we've seen that there's a probability around 10% of the patients to have a different window of implantation, and therefore maybe they will need to change their protocol of preparation. So this is something that we can look at, as I say. Even they say, the studies say that around 30, I said 10%, but even around 30% of the patients normally with implantation failure or recurrent problems could have this window of implantation displaced. There are several tests right now that we can use. One of them is called the ERA test. Another one is called the time test. Well, either of them do the testing of several genes to see if the endometrium at the point at when we are doing the biopsy, if the endometrium at that point is receptive. So what we do is the same as if we were going to do an embryo transfer. We do an endometrial preparation, no matter what type of protocol we use, but at the point at when we were going to do the embryo transfer is when we are going to do an endometrial biopsy, which is normally done at the consultation. It's quite easy. And several days after, we get the results to see if this woman is receptive at that point, or if we need any changes at the protocol of preparation. What are the indications then? When do we normally do these tests? We will do them when we consider an implantation failure. That is when we've done several, normally more than 2 blastocyst embryo transfer without success. Also, maybe if we've done only 1 embryo transfer unsuccessful, but the embryo was directly euploid, we also consider that maybe we should be doing this type of testing. And well, also in general, we can do it in any patient. We can explain it at the consultation that we have this option to, let's say, have a better approach on their endometrium, have more information, and have a more personalized embryo transfer for them with a personalized protocol of preparation, depending on the hours of progesterone that they need. Regarding the endometrial tests, there was a second option that we can do separately from the window of implantation that we were talking about, or also we can do both of the tests at the same point, at the same time, with the same endometrial biopsy. Here, the other option will be to check the microbiome of the endometrium with the testings that are called ENMA and ALICE or META tests. They will, both of them, look at the microorganisms that we have inside the endometrium. So it's normal that we have bacteria over there, but let's say that the normal bacteria that we need for an implantation to take place and a developing pregnancy to take place, it's called the Lactobacillus species. That's the one most important over there. There are other good bacteria species, let's say, but this is the basic one. No? There could be pathogenic deviations in the dominant microbiome, meaning that if we don't have that percentage of lactobacilli needed, that normally is more than 90% of this type of bacteria. If we don't have that, then maybe we could get some infertility problems such as implantation failure or also miscarriages. So then we need to check, or we can check this with as well. It's again a DNA study of the bacteria that we have inside our endometrium. Here with this graphic, we can see, with this graph, sorry, that in a, let's say, normal patient that has normal pregnancy, ongoing pregnancies, the population of Lactobacillus, as we were talking about, that's the blue part, is completely dominant from the rest of the bacteria. In patients with recurrent miscarriages or implantation failure, we also find that type of bacteria, but as you can see, there are different other bacteria coming out in the result of the DNA testing, no? So this is important to take into account and maybe give them a treatment to try and have a good microbiome again inside the uterus. But not only it's going to tell us, as I said, if our microbiome is fine, it also, the same biopsy is going to tell us if there are any pathogens that or bad bacteria that could be causing a chronic endometritis. This is an infection that could be long-term inflammation of the endometrium and that doesn't give any symptoms. Obviously, if this occurs, we need to put normally an antibiotic treatment to try and let's say stop that infection or inflammation going on, and also see if we need normally treatment with probiotics to have a good microbiome as well. So this type of testing is also very important. When do we consider that we need to look at the microbiome or check that we don't have infections at this the endometrium? So as well, same as before, implantation failure patients, also recurrent miscarriages at this point, and even in patients that we consider that the lining of the endometrium should be working properly with the protocols and it doesn't work, we don't get a good endometrium, maybe after several treatments, if we see that we don't get the proper endometrium for a transfer, then sometimes we go ahead and test for the microbiome and infections, just in case, no? Because sometimes it could be a sign that the endometrium is not healthy. And in general as well, whoever wants a better approach of the endometrium before doing an embryo transfer. So what are the ideas that we have to take home today before all this information, after all this information, sorry. So let's say that the endometrium is also extremely important for the fertility treatments. A good endometrium may increase the implantation rates, so we do have to consider it very importantly, as well as the embryo quality, for example. Take back home the idea that apart from the basic examination regarding the lining of the endometrium, the aspect, the thickness, we also have several endometrial tests that we can do to have much more information rather than only the ultrasound image, no? And obviously the main goal about everything we've talked today would be to improve reproductive outcomes. So hope that all this information is useful for you, and now I'm open to answer all the questions that you may have.
Brilliant. Thank you so much. As always, this has been very, very useful and thorough. So thanks a lot for this, Dr. Santiago. And you are very right. There are plenty of questions right here. So let's get to them, okay? Some of them are quite long. I will try to show them one by one. They are all connected sometimes as well. So let's start with the first question from Karen. There will be a follow-up, so I will show you both and then I will show you the first one. So let's go ahead. Karen, thank you for the first question. So is the level of serum progesterone indicative of uterus progesterone level? I tested my levels before and after frozen transfer, and the level dropped significantly. Despite progesterone pessaries injections, would this be normal, or you would expect level to be stable to continue to rise rather than drop? I had chemical loss on that occasion. And in case it helps, sorry.
Yeah, so maybe we lost
Just give me
the
a second.
connection a little bit, Caroline.
Can you hear me? It was, but all should be now. So bear with me. I think I can help you with. Yeah, sorry. This is the second part. In case it helps to know the progesterone level 1 day after transfer was 43.22 nanograms, and then 3 days later it was 38. It is different measurement, of course, and I understand this is much lower. Yeah. Sorry.
Yeah, it is. Yeah, we have to take into account the units. Well, let's see. I'm not we're not yet maybe experts in progesterone levels at all times during before the embryo transfer, after the embryo transfer. It's not something that needs to be increasing all the time. Normally, it's something that it should be more or less stable from when you've begun with the progesterone supplements in 24 hours. If you are taking the same medication, it should be stable. Obviously, we have to take into account, first of all, where you've done the tests, because maybe if you do them at a different lab, maybe you can get different levels as well. As you can see, the units are not the same. Then what the let's say evidence tell us is that we have to check blood levels to assume that we are having correct levels for the embryo transfer and therefore implantation to take place. Until now, I think this is not something that it's normally done in the uterus. It's something done in the blood. So as I said, if you have less than 10 nanograms per milliliter blood levels after at least 24 hours with your treatment, then go ahead and put subcutaneous progesterone. But normally with that added to the pessaries should be enough. If you have more than 10 nanograms per milliliter, this should be enough. And also you have to take into account when you are doing those blood tests, at what point of the day, because maybe that also varies, no?
Brilliant. Thank you so much. And let me just go straight to the current question. Do you recommend injections that you can do daily or twice weekly?
Okay. Here, take into account that there are different types of progesterone. Normally, the subcutaneous one is daily. As I said, it should be 1 or 2 shots per day, depending on the protocol, or if we are adding it up to the vaginal progesterone. The injections normally twice a week. It's another type of medication. This is intramuscular progesterone, and obviously their pharmacodynamics, everything is different. So that's why let's say the protocol is different too. At first, intramuscular progesterone is absolutely valid. It's not something that we use a lot here in Spain. That's why I didn't mention it. But I know that in other countries, such as in the US, they use it a lot. And obviously, you can get very good levels of progesterone with a protocol, even only twice weekly.
Brilliant. Thank you so much indeed. There are plenty of questions coming up, so let's get to them. It's very, very busy in the chat section. So let's have a look. Next question is a bit of a longer. Let's have a look. Sam, I am having my third IVF cycle. I have had a mini cycle and I'm on day 1 with 1 fertilized egg. All my cycles have resulted in 1 egg retrieved and the rest have been empty follicles. Last cycle we had an embryo transfer, but I gave GA as was too painful vaginally. Okay. This third round, they were unable to access my ovaries as my fibroid has grown and went through my stomach. This seems to have got bigger since starting IVF due to medications. My fibroid is 12 and sits on the left uterus. I pray I get to embryo stage and get the transfer in a few days. Currently on 800 progesterone. Can this fibroid affect my chances?
Okay. Difficult question, difficult to absolutely have an answer with all the evidence for you. But I mean, if the fibroid is not affecting the endometrium, maybe it's not at a point, obviously, outside the uterus where it does affect for the egg retrieval to take place vaginally, that things could happen. But if it's not affecting the endometrium and it's not very big, let's say in intramuscular, it's more an exogenous fibroid, let's say, that shouldn't be affecting the chances of implantation. But obviously there are too many things that have to be considered in your case, and that right now I don't have all the information to absolutely be confident telling you that it doesn't affect.
That's understandable. And of course, remember that you will be able to get in touch with Dr. Santiago, her team at Clinica Tambre. I know that someone already asked about this, and that way you can ask, of course, ask for more details, etc. And also, Dr. Santiago will definitely need more details. Could you remind me what is the email address? That also it's a possibility to get in touch with you and your team.
Yeah, sure. So I think I wrote it down here before entering the webinar, but absolutely.
Okay, sure.
It's Santiago clinicatambre.com.
Brilliant. Thank you so much. Then I will put it in the webinar, chat
Thank you
section
so
in a
much.
second. So if anyone would like to get some more details, it will be possible. And let's have a look at the question from Christina. Okay. I have 6 frozen day 3 embryos. These are the only embryos we have. It took us several IVF cycles to accumulate these 6 embryos. My embryologist advised freezing on day 3 because we only had a few, so we want to give them the best chance. 3 of these embryos are top quality and the other 3 are good to fair quality. How do you recommend the transfer? 2 at a time and starting with the best. I am a bit worried not to lose both of them if there would be an issue occurring after the transfer, maybe with the endometrium.
Okay, obviously endometrium needs to be checked before embryo transfer, that for sure. It shouldn't be something that we find out afterwards that there's a problem or anything. If you want to be absolutely confident about your endometrium globally, I do advise you to maybe do the testings that we were talking about before going for the first embryo transfer. As they are day 3 embryos, normally to have maximum chances per embryo transfer, is better to put 2 together. Obviously, it depends also on your medical conditions. If you have any problems over there, your age, this is something to be considered by your doctor, because by putting 2, we do increase a little bit the risk of twins, and this is something that needs to be considered. But in terms of global chances, it's better that you transfer 2 by 2, and normally protocols with the lab will be to go first of all with the 2 best ones, then decreasing the inequality for each embryo transfer. It doesn't mean that the best ones are going to implantate for sure and the other ones won't. So, I mean, it's a way of selecting embryos in an order, no?
Thank you so much, Christina, for your question. I hope that was helpful for you as well. Karen has another question. How do you most effectively treat low level of lactobacillus?
The most effective way, they say, is to use lactobacilli probiotics directly with vaginal pessaries of these probiotics. So there are like concrete preparations that normally they sell at the pharmacies, or even online you can get them sometimes. It's not a medication itself, and I mean, normally it's easy to get it, and it's better if we do it vaginally rather than oral probiotics.
All right, understood. Thank you so much, Karen, for that. Oh, actually, Karen has one more. What are your thoughts on having endometrial scratch as part of the preparation?
Well, good question. I didn't mention that because it's true that with the evidence that we have, and it's been several years that maybe this has been used, sorry, and we never find out that there is evidence that when doing a scratching, things are going to improve or get better chances of implantation. So it's not something that we normally do. I mean, we don't find there in that research that it's going to improve our outcomes. So we normally don't use it. But I mean, if your gynecologist maybe suggests using it just to do something else or something different, it's not so invasive, and yeah, go ahead. But for me, it's much more valid doing the endometrial testings that I've talked about, because we will have much more information with that rather than a scratching. Also, take into account that if you do an endometrial biopsy, the cycle previous to the endometrial preparation, you are also doing a scratching. So it's absolutely the same, okay? The endometrial biopsy itself is doing a scratching in the endometrial, but I don't think that this is the reason why outcomes may improve after doing the endometrial testing.
All right, understood. Again, thank you so much. Now we will have 3 questions. I will show you those questions one by one from the very same person. Sima, thank you, Dr. Santiago. This has been amazing, really helpful. I made lots of notes. And the first question is, apart from progesterone and estrogen, what are these supplements to help thicken the lining for frozen embryo transfer?
Well, normally this is the basic treatment, but to thicken the lining in women that don't respond to this treatment, sometimes we do have to use other types of medication, such as vitamins, for example, vitamin E. Sometimes also we use aspirin. Other times, maybe if the woman has regular cycles, we can use gonadotropins as if we were doing an ovarian stimulation instead of putting exogenous estrogens. So there are different options depending on each patient, obviously. But let's say that the basic one is the one that we've talked about.
All right, thank you for that question. And there's another question from the same patient. What does supplements increase blood flow to the uterus? And what are your views on eating pineapple core after embryo transfer and having pomegranate juice before embryo transfer?
So supplements that increase blood flow to the uterus, the one that I mentioned, probably the vitamin E or the aspirin, anti-clotting, let's say, treatments, but not always considered to be useful in every patient. It depends on each individual case. And the third question, what are my views on eating pineapple or juice, pomegranate juice? Honestly, I don't have any experience at all with this. I mean, absolutely, I can't help you with that because I don't have the experience.
All right. Okay. Thank you so much indeed. Let's have a look. Alma has another question. So, do you think recurrent implantation failure can be due to an autoimmune disease, psoriatic arthritis, psoriasis? Sorry, not sure here. There appears to be a lot of diverging opinions on what impact the immune system can have on implantation pregnancy.
Yeah, sure. There are lots of cases where maybe recurrent implantation failure is due to the immune system, no? It doesn't have to be related to having psoriasis, arthritis, or psoriasis by itself. This depends on each case, but normally it's true that maybe if you have already an autoimmune disease, maybe you can get some other factors going on during the implantation that could be affecting. So my advice would be always, if you have implantation failure in your case, go ahead and have a special consultation with an immunologist, which will be the specialist that will consider all your medical record, see what tests you need to do, normally blood tests, and see if you need any other medication added up to, let's say, the basic protocols that we've talked about.
All right. Again, Alma, thank you so much. And Dr. Santiago, as always, very useful. Let's have a look. More questions are coming up. And this is from Lisa. What are your thoughts on embryo glue, please? Is this a useful tool for implantation?
Okay, good question as well. Same answer or similar answer to the scratching. For us, when going through all the articles and scientific evidence about this, we don't see that it significantly improves the pregnancy rates. So it's something that we don't have the experience because we decided at a point that we are not going to use it, as we consider that it doesn't improve the results when using the glue or when not using it.
Okay, thank you. How about this one from Belinda? If you have an era as it's a mock cycle, is there a chance the actual cycle for transfer may have a slightly different implantation window? So there is no way of knowing each cycle is the same?
Look, that's a very good question, Belinda, but the proper labs that do all this endometrial testing tell you that normally the window of implantation is going to be the same for each patient. It's true that if it takes very, very long from when the endometrial testing was done until we do the embryo transfer, I'm talking about several months or even years, maybe that window of implantation can get changed within time. But it doesn't mean that from one cycle to another it's going to change. So normally it's something that also it's going to be quite constant. It's true that when doing this type of testing, they do recommend to do it the cycle just before embryo transfer. But once you do it, even if it doesn't work with the first embryo transfer, go ahead with the same protocol they've told you, because probably the window of implantation will still be the same.
Okay, thank you so much for that question indeed, and for your help with that. And there's another question here. Okay, sorry. This is a follow-up, okay, in regards to the previous question you already answered. I'm in menopause, and then a fresh transfer 2 years ago was successful. I did frozen embryo transfer 3 weeks ago, was unsuccessful. I wanted to ask, is Orbitrel that I used was not fridged when it was shipped to me, Israel from US, and then I fridged it after it arrived. I used it after 7 months, but it wasn't fridged again on the plane, US to Prague. Does that play a big factor? Why is the frozen embryo transfer unsuccessful? Why was it unsuccessful?
Okay, Kyra, I'm not sure if this could be the cause of non-implantation in your case. Obviously, all the factors count, and it's true that when we need to have a medication kept in the fridge and maybe we don't do so, normally for some hours it's not such a problem, but obviously, yeah, it could be another factor. But here the thing is, the only thing that we could check is really, is this medication doing its proper effect or not? It doesn't mean that if it's not fridged, it's not going to work for sure, okay? And obviously there are many other factors that interfere in that implantation. So I can't absolutely tell you that this was the cause, not at all.
Of course, that's understandable. Again, thank you so much. And let's have a look at this question. I just got a negative after frozen embryo transfer. Everything was good, but have a 6.5 centimeter subserosal fibroid. My doctor thinks it might have caused the loss and recommended myomectomy. What do you advise?
Okay, so the same as we were talking about fibroids before, it depends on where is this fibroid. It's true that, let's say, it's not small, it's not very, very big, but if it's subserosal, it means it's outside the, let's say, part of the uterus, and this type of fibroids shouldn't be affecting the implantation unless there is like more than 50% of that fibroid affecting or in an intramuscular uh, situation. Yeah, so it depends a lot on what your doctor considered or considers. It's true that if it has a big part of it affecting the muscle of the uterus, maybe this could be affecting also the implantation rates. But if it's absolutely subserosal in more than a 50%, this shouldn't be affecting the implantation rates.
All right, thank you for another advice here. Okay, let's have a look at the next question from Derek. Do you have any data regarding endo on age and or BMI?
So regarding endo, I don't understand the question.
Yeah.
Regarding endo on age?
If you can, yeah, on age or BMI, does it have any, I think, anything?
I suppose, no, the age,
Sure.
the pregnancy rates, no?
Derek, if you can clarify perhaps, so we can make it, we can, answer properly. Please just explain exactly what you mean by that, okay? And we can show the question once again, okay? Thanks. All right, let's have a look at the next question. It will be a bit of a longer question here. Okay. I have done embryo hatching due to low AMH and ovarian reserve. So we now have 7-day 5 blastocysts in freezer after 10 eggs collection in total. We haven't tested our blastocysts as we only made one blastocyst on each round. We did frozen embryo transfer of 2 blastocysts last year, had my first ever pregnancy, but ended in chemical. We did immunology testing, which showed slightly raised NK cells. We are now waiting for 3 months to get in shape mentally, physically, and then we'll do frozen embryo transfer in August. Would you recommend to transfer 2, as I will be 43 in September? Also, your opinion on IVIG, intralipids, pred, and if I should do ERA, Emma, Alice.
Okay, Belinda. Look, I don't believe that double embryo transfer is going to help you. Okay, when doing the transfers in a blastocyst stage, I absolutely defend or go ahead with the advice of doing single embryo transfer nearly always, if the quality is good. All right. This is because double embryo transfer is not going to increase your total chances of pregnancy, and on the other hand, is going to increase the risk of having twins, which is not something to not bear in mind. I mean, the risks during pregnancy are going to be higher if we have twins. And also sometimes even immunologically, now that you're asking questions regarding the NKs and everything, immunologically they say that when we put two embryos together in a blastocyst stage, maybe they are not helping each other for an implantation to take place. So even immunologists recommend more a single embryo transfer rather than a double embryo transfer. In the other hand, what do I think about intralipids, prednisone, all these therapies? If immunologically they consider in your particular case that this is an indication, then go ahead. It's true that it's very difficult also scientifically to prove that this works, but I do believe that when it's needed, then it's better to use it rather than not putting this type of treatments. And the last question regarding the ERA, IMA, and ALICE test. Obviously, I think that it's something very easy to do before another embryo transfer. So yeah, I do recommend you to go ahead with that if you can, because we are going to have much more information before the next embryo transfer takes place.
All right, brilliant. Thank you so much indeed. And there's a thank you from Belinda. Thank you so much for answering all my questions.
Thank you,
Brilliant.
Belinda.
Thank you indeed. And let's have a look. Derek has the question here. Okay, so this is what he means. Have you seen any endometrium differences in both age and BMI?
Thank you, Derek, for clarifying that. Look, normally age is not something that makes us more difficult for an endometrial preparation to take place or a good endometrium for an embryo transfer. I don't think this is something that should be affecting. It's true that sometimes in menopause women, we have like less blood flow in the uterus, and sometimes it's a little bit more difficult, but it's normally not the cause. Body mass index is true that sometimes it could affect in the proper effect of the medication that we are putting, meaning that maybe it's not doing the complete effect that it should. But I think that here the problem is more in terms of implantation rates and developing pregnancy rather than endometrial preparation. I would be more worried about those pregnancy rates, as I say, rather than endometrial preparation in these cases.
Okay, thank you, Derek, for clarification, and Dr. Santiago, thank you for explaining as well. And thanks so much indeed. And let's have a look. A few questions are left right here. And which probiotic do you give?
So there are lots of different probiotics, and also it depends on the country. You just have to look at the components, and normally any type of Lactobacillus, because there are other subtyping in the same species. Any of them that is vaginal will be normally valid.
Okay, thank you. Okay, Karen has another question. I did ERA, EMA, ALICE, and all was normal with exception of Lactobacillus. The bacteria was not different from the water solution, so very low level. You mentioned that low level can cause implantation failure or miscarriage. Would this happen very quickly after implantation or in later weeks?
It depends. I don't absolutely know when this could affect, but I mean the same as other things in reproductive outcomes. Probably if you have a low lactobacilli concentration, this could be affecting not only implantation, as we've said, but also increasing miscarriage rates, normally more at the beginning, but it doesn't mean it has to be a biochemical pregnancy. Sometimes that pregnancy does develop a little bit more. It normally will be always a miscarriage during the first trimester.
All right. Thank you. Thank you so much for this as well. And next question, it's right here. So do you recommend fertility reflexology during IVF treatment? When it is best to receive it? Anything you can help with?
Well, difficult to know, really. It's not that I don't believe in this type of therapies. I agree that if it's good for you, probably it will help. But once more, I don't have any scientific evidence for that, as well as, for example, acupuncture. But absolutely, I'm not against it. So if you feel good doing this type of therapies, for sure, they can help.
Brilliant. Thank you so much. There's another question, but I guess this will be similar answer, right? So can reflexology extend the window of implantation? As you said, it's hard to prove scientifically, but
Correct.
Exactly. Thank you so much indeed for the question indeed, and for your answer to that. Okay, let's have a look. Sebastian would like to know. Sorry, I lost it. I need a second. Okay, any recommendations to you for a thin endometrium?
Sorry. So when we're having thin endometrium, it depends on the case as well. Normally, during a first endometrial preparation, we try in a different cycle. So we cancel the treatment and we try again, maybe with the same protocol, maybe increasing the dose, or maybe giving different types of, for example, estrogens. If we gave it orally, maybe we can give it vaginally or with patches differently, to see if the absorption maybe is better for that patient. Other options, as I said, maybe are giving different vitamins, sometimes also aspirin, or sometimes doing different protocols, such as with gonadotropins, stimulating the ovary to get endogenous estrogens produced by the ovary, and therefore sometimes it's better in thickness for some of the patients.
Thank you for yet another interesting question and for your help with that. Fran would like to ask as well if you can have a look. Both endometrial tests will require biopsy, so mock cycle. Would you recommend both these tests are completed?
So always when doing a window of implantation checkup, we will need a mock cycle. For the ENMA ALICE or META tests that are looking for the microbiome, we don't need that mock cycle if we are not adding up the window of implantation. For that type of endometrial biopsies, we will need to do them in a second phase of the cycle, meaning after ovulation, during normally between a day 15th to 25th of the cycle.
Mm-hmm. Brilliant. Thank you so much. There are like 3 questions left. We will be finishing slowly. So if you have anything left, just go ahead, type those in. But also remember, there is an option for you to get in touch with Dr. Santiago directly and her team. That will be even more helpful, I'm sure. Let's have a look. Okay, Sarah has a question. So I'm 33, have premature ovarian insufficiency. I just had a cancelled round of IVF due to no follicles maturing. Would you have any advice for endometrium preparation for my particular case? My clinic will not try to retrieve any more eggs. Next plan is to unfreeze 2 eggs with the aim of forming embryos for transfer.
So Sarah, at first, don't worry, because even if you have premature ovarian insufficiency, it doesn't mean that your endometrium won't get well prepared. I do recommend, maybe if you are not having right now regular cycles, to go ahead directly with a substituted cycle, meaning putting estrogens from the start. But for sure, it can work in the same way, even if you're not having periods.
Okay, thank you so much for reassuring Sarah here as well. Thanks so much indeed. Okay, let's have a look. Sorry, just a second. In terms of the success rate of an embryo transfer, what percentage would you give the role of the endometrium and the embryos?
So giving a percentage is very difficult, because also it depends on the age of the embryos and everything, on the women that did the treatment of the embryos and everything. But in general, it's more important in percentages, the rate in the embryo, and second of all will be the endometrium. But obviously it's also very, very important.
Okay, thank you again for that. Karen, thank you for that question as well. What are your thoughts on dam regulation injections such as ProStap and part of preparation? As a part of preparation, would patient age influence this decision? Sorry if this was discussed at the beginning. I missed the first few minutes. It's okay.
Yeah, so we haven't spoken about this type of protocol because honestly, that's not something that we normally use. So I suppose it's another option, but I'm not really used to do this type of preparation. So sorry, because I can't give you more information here, Karen.
Understood again, of course. Thank you so much still for that. Okay, let me have a look. Here's the next question. So, for how long do we have to try to prepare the endometrium in frozen embryo transfer if the embryo transfer is still, ET, sure, is still low?
Well, normally you don't have to do a very long preparation. Let's say that the preparation will take around 3 weeks' time in total, but it shouldn't go more than 4 to 5 weeks. So you can try and maybe add more medication at the stage where you see that 10, 12 days after putting the medication is not thick enough. You can add more dose and do another checkup maybe a week after. But if this hasn't improved at all the aspect or the thickness of the lining, then I think it's better to cancel and start all over again rather than going for a longer treatment.
Okay, thank you so much for that again. Okay, and have you heard of someone going straight to IVF and not starting with IUI? My doctor told me that it would be best to start with IUI. I am in my early 40s.
Yeah, absolutely. I have loads and loads of patients that go straight for an IVF without doing IUI before. It depends on each case as well. In my opinion, if you are more than 38 years old, go ahead directly with an IVF, because you will have much better chances of getting pregnant rather than doing IUI cycles. We don't have enough time over there, and that's the reason why. Even I also have patients that go directly with egg donation treatments because of age. It's not maybe your case, but I do suggest considering IVF directly.
All right. Thank you so much as well from Liz for your help with that. Thank you indeed.
Okay.
Let me have a look. How about embryo glue? You have mentioned this before. Is
Yeah,
offered as it is offered as standard at UK clinic, but you think it is not particularly necessary or helpful?
correct. I don't think it's particularly necessary or helpful because of the evidence that we have when doing studies, no? So it's not something that we normally use.
Of course, thank you for the clarification. And let me just show you this question. I know you mentioned at the beginning that some clinics may do day 2 transfers. Why would they do this over day 5, as it isn't as isn't it a better chance if a blastocyst has been made as in day 2? Seems too early.
This, Belinda, depends a lot on the protocol of each clinic, also the experience of the lab. So maybe they don't have enough experience in doing a long culture until a blastocyst stage, and that's the reason why they want to go ahead with day 2 or day 3 embryos. Also, there are lots of people working in reproductive treatments that prefer maybe putting a day 2 or day 3 embryo rather than waiting for the blastocyst stage, just in case they don't have embryos at all finally. It's not the way we normally do things. I do believe that it's better to always go ahead with the blastocyst stage, even if we don't get a good embryo quality and we don't have an embryo transfer at all. I think that's the best option.
All right. Again, thank you so much, Belinda, for yet another question. I believe it has been very, very useful to all of you. And as I've mentioned, we will be finishing. So thank you, everyone, for joining us tonight. This has been a very busy Q&A session, and I'm very happy that we were able to help you out with some of the questions. Dr. Santiago, as you can see, there are plenty of thank yous coming up your way. Great presentation, very helpful answers. So as you can see, this has been really useful. So I just want you to have a look. And let me just check. Yeah, there are more thank yous coming up. So anything else you would like to add before we finish for today?
Yeah, well, take into account that in reproductive outcomes, treatments, there are many, many factors. Biology is not as it is a science, no? It's never going to be 100% one result or another. Sometimes it's very difficult even for us, the doctors or the biologists, to know about the outcomes. We try to help in all that we can, using all the techniques that we can nowadays, and trying to give our best to patients. But sometimes it's true that it's not so easy. So, well, regarding the endometrium, this is what I thought nowadays is more important for every endometrial preparation, and to consider the testings, the let's say endometrial preparations, to try and have the best option. That's what we need to be done. Okay.
Brilliant summary. I couldn't agree more, for sure. So thanks a lot. As you can see, very thankful right here, everyone. So thank you so much for joining. I just want to mention that we will be back actually this Thursday. We will discuss male infertility, and we have a special guest, Professor Cheryl Homa will be with us. And I just hope that you will be able to join us as well, because I still think that that male part is very, very often omitted. So if you can join, perhaps you can bring your partners, your husbands, and I hope that you will be able to join us, and we'll have more questions. As you know, there are plenty of webinars coming up. So go ahead, check my IVF Answers and our upcoming events. Dr. Santiago, it has been great to have you here. I do hope that we will have another chance to see you soon. And of course, it has been a brilliant session. So thanks a lot for your time. Now, everyone, have a lovely evening. Dr. Santiago as well. Have a great evening, and
thank you so much.
See you soon. Okay.
See you soon. Hopefully.
Thank
bye
you so
bye.
much
Looking
indeed.
forward to it. Bye.
Take care. Bye.
Thank you.